I'm going to present my subjective views on the diabetes technology from my practice. But again, remember, I'm practicing in Michigan, the US, and so I don't know what you have available, but let me just take you through a journey through diabetes technology. And it's been quite a journey. If you think about it, where we started, my grandfather had type 2 diabetes, and he was every night sterilizing his glass syringe. He was sharpening the needle, and he was pissing on a test tape to find out where his sugar was. A little bit different now, right? So we are now actually finally getting to the stage of hopefully getting close to the closed loop or so-called artificial pancreas system. So what are we doing right now as far as being able to help our patients manage their diabetes as far as technology? First of all, the question comes up, what is a diabetes technology? What do you mean by that? So I assume here, because it's a sophisticated audience, you know, but let me just make sure that we understand each other. We talk about continuous glucose monitoring, continuous insulin delivery via insulin pump, the data management, and of course, the device connectivity. And this is where the automated insulin delivery comes in. But why should you care? Well, hopefully, you'd like to improve the lives of patients with diabetes. And there is a sort of quadruple aim of this right now. FDA actually in the US has led a charge which they call Beyond A1C, which is maximize time in range, minimize time in hypoglycemia, minimize glycemic variability, and optimize patient-reported outcomes. You can imagine the last one is very difficult to quantitate. We can quantitate the first three. The fourth one is a challenge because there are no good instruments to evaluate patient-reported outcomes. So we are not talking anymore about decreasing A1C, which is in contrast to all the drug trials you heard about, right? The primary endpoint is always the A1C decrease, not how patients feel, not if they're doing better, the A1C. So this is not about A1C any longer. Let me just go back to say, okay, does it make sense? If you look at the T1D exchange data, which was published a little bit back, whether you're talking about kids or adults, the more frequent you do finger stick for the glucose, the lower the A1C was. And guess what? People who use continuous glucose monitoring had better A1C, no matter what the age was. And patients who used insulin pumps had better A1C, regardless of the age, than patients who did individual injections. But guess what? Regardless how you stick insulin under your skin, whether it's by the insulin infusion or individual injections, patients on continuous glucose monitoring seem to have better glycemic control. So this is the background. So it doesn't make sense. Okay, so now, what is the continuous glucose monitoring? People ask. And remember, this is not blood glucose. If I hear one more time somebody refer to this as blood glucose, I'm going to scream. But remember, the probe sits under the skin in the interstitial fluid. You're measuring glucose concentration in interstitial fluid, not in blood. And patients get obsessed, always try to compare. Well, I have a different result. Of course I have a different result. First one is a physiological lag. And the thing is monitoring glucose concentration in different medium. But if you think about it, the continuous glucose monitoring provides so much more data. Typically, most devices report every 5 minutes. So if you think about it, in 24 hours, you get 288 readings. I don't have too many patients in my practice who are willing to do 288 finger sticks each day. So the other thing, of course, it allows you to do is you can start looking at rates of change. And clearly, it allows some prediction because if you can sort of figure out where you're heading. Because when you do a finger stick, you see where the glucose is right now. You have no idea where you came from or where you're going. For CGM, obviously, it's very different. And also now, because of those changes, you can have alerts and alarms. And hopefully, you can improve the time to treatment because you know what's coming down the pike. And of course, now you can also talk to relatives, friends, enemies, whatever, because they can actually monitor remotely if you have an app and a smartphone. So let's go back. you have a very good patient. There are some patients actually willing to do 4 finger sticks a day. So let's assume the patient is good. And a day is going to have 4 finger sticks. Well, the best you can do with that data is to connect those dots. You have no idea what happened in between. But guess what? The same patient on a continuous glucose monitor gives you a little bit different information. Look at the time spent in the morning, much higher than you think from the finger sticks. So you totally miss the postprandial, post-breakfast hyperglycemia in this example. Hopefully it makes sense. Now, FDA has been trying to figure out, okay, how do you allow these devices to enter the market? And what's being plotted here is the progress we've made from your upper right down to the lower left over the years, which each device, each number is a new device in front of FDA. How the accuracy has improved. What's plotted here is on the horizontal axis, MARD, mean absolute relative difference. That is the measure of accuracy. That is, how far are you from the gold standard plasma glucose concentration measured by the yellow spring instruments. So MARD is a measure of the accuracy. And on the y-axis, you have percentage of readings which are more than 20% off. So clearly, the more you get to the lower left, the better you are. And the green rectangle basically tells you that FDA decided, federal bureaucrats decided in the US, that once the MARD is lower than 10%, you can trust the results from continuous glucose monitor to make decisions about insulin dose. You don't have to compare with finger stick anymore. And the point is that the new devices are all in that green rectangle. So let me just quickly go at least through what's on the US market as far as the continuous glucose monitor. Let me start with Medtronic. And so again, you have that probe in the interstitial space. And what happens, the electron current is sent to the transmitter, and the transmitter converts it to a glucose reading, because otherwise you wouldn't know what it means. And the transmitter then sends the data either to a dedicated receiver or directly to an insulin pump if the patient's on a pump. There are two devices right now in the US as far as the Medtronic, but I'll just tell you about the latest one which is on the market, which is the Guardian Sensor 3. And that system is more accurate than the preceding systems, and it's there for 7 days. So the patient is replaced every 7 days, and actually has a chip inside, diagnostic chip. And if the sensor is sick, the patient gets actually a message, hey, fix the sensor, there's a problem. And the performance, okay, how does it compare? Remember, I said MARD under 10% is approved to be used without finger sticks. If you do 3 to 4 calibrations with finger stick each day, the MARD is less than 10%. If you do 2 calibrations a day, you still have to calibrate. Patients still have to calibrate finger sticks to make sure that's okay. It's a little bit above the 10%. Okay, so this is the Medtronic performance. And patients either use it now, that sensor, as part of the hybrid closed loop system, which is the Medtronic 670G, or separate as a standalone with the Guardian Connect, when the sensor sends data directly to the smartphone. Again, 7 days wear, and so the patient has to change every 7 days. Dexcom, another company which has product at least on the US market, the latest model is the 6th generation, Dexcom G6, and that one is good for 10 days as a new sensor, new algorithm, and actually it lasts for 10 days. What's really nice about it, no calibration is needed. Patients don't have to do finger sticks anymore. So it was the first device when basically it's accurate enough that patients don't have to do finger sticks and they can read directly the readings and use that. Has an applicator, so all you have to do is press the orange button and it inserts. You throw the rest out with a waste, but it's a different story. The transmitter is good. You snap the transmitter on the sensor. It's there for about 3 months. And you can send the data either to a dedicated receiver, or most patients actually like to just have an app on the smartphone and it goes directly to the smartphone, and then you don't have to worry about carrying extra receiver around. How's the performance? If you look at the G6 in the right column with no calibrations, it is under the magic mark of 10%. Just to compare it to the 5th generation of Dexcom, which needed still 2 finger stick calibration each day, but it's a comparable accuracy. So again, it's approved to be used without the need for finger sticks. And it has features because remember what I said, that this thing can actually predict what's going to happen because you see the rates of change. So not only that you get an alarm when you have a hypoglycemic reading, it can predict and will give you a signal, alert, and alarm. You're about to be hypoglycemic. Next 15 minutes, do something. This is also the first device which doesn't have interference acetaminophen because the other ones did. And so there is no influence there. Now, again, the magic word right now is this interoperability, that the devices talk to each other. And so you have a sensor, and it can send a signal to the receiver, to your smartphone, to your watch, or God knows to what. And you can send it to the Mars, you can send it to friends in Australia, and then your mom can watch you when you play soccer. And so it's a totally changed world now when the data are available and the monitoring, whether it's the school nurse or whether it's the parents, can see what's going on and do something before bad things happen. So as I mentioned, for the FDA, at least in the US, it's all about this interoperability. And this designation of ICGM is new. Basically will mean that if your device gets that mark ICGM, then basically you can communicate across any platform and you can hopefully eventually pick things off the shelf. So you can pick one device for sensing, another device for insulin delivery, another one for the smart brain, which connects it, and whatever. What's coming, but it's not on the market yet is the Dexcom G7, which is the first product of the cooperation between Dexcom and Verily, where is the offshoot of Google. All the big companies, whereas Apple, Google, all these are now in healthcare. And I don't know if you've seen the announcement yesterday, Apple is now actually selling glucose monitors in the stores, not just online. They're all getting into healthcare, and diabetes is a big business, like it or not. Now, that, once it's approved, is going to be 14-day, much smaller, and hopefully less expensive also, which obviously matters a lot to most of the patients. Let me change to something else. This is Abbott, and it's a different system. It's so-called flash CGM. And so this is intermittently scanned CGM. What does it mean? The patient, this is for 14 days, no calibration needed. The patient will place the sensor on the back of the arm every 2 weeks, but they don't see what's going on. You have to actually physically scan it. So it's an intermittently scanned thing. So you have your either smartphone or your receiver, you scan it, and in 1 second you'll see the data again. But remember, unlike with a finger stick, you not only see what the reading is, like in this case 112, but you can see on the bottom, you can look at what happened over the last 24 hours, 48 hours, the last week, months, 90 days. You can see the trends, but also from the arrow, you can see the direction, the angle of the arrow, where you're going. It predicts where you will be in the next 30 minutes. And so you can get these predictive alerts. No calibration needed, no finger sticks needed, and it's, again, then granted, this designation is non-adjunctive, which means you do not need a finger stick to confirm. You can actually make insulin dosing changes based on the reading. And it's approved for kiddies. For adults, it will be approved for kiddies soon. I don't know how much you sort of remember this Clark accuracy sort of grid. It tells you, well, how good is it? So basically, in this grid, you plot the results from the CGM versus, again, gold standard plasma glucose. And if it's in the zones A and B, that means for clinical purposes, it's accurate. Once you are beyond in C, D, or E zones, then you have a problem. So you can see here 100% in that A and B zones, and it retains the MARD under 10% over the duration of the sensor. As I mentioned before, the arrows allow you, the patient, to see where the patient is going to be over the next 30 minutes. If it's going straight up or down, that means that glucose is changing by more than 2 milligrams per deciliter per minute. And again, you can take action, hopefully, then before you get in trouble. As I mentioned, you can scan it with a smartphone if you want to. This is a fascinating study. Well, let me rephrase. It's not a study. What's really scary, every time a patient scans, Big Brother in the sky, in a cloud, see what's going on. So these people are not in a study. You have 500,000 people. There was about 5 billion readings. And basically what's plotted here, remember, patients don't know they're being monitored, no doctors involved. The more frequently patients scan, which is on the horizontal axis, the lower the A1C was. But that's not a big deal. Big deal is that also there was less hypoglycemia. Think about that. By just scanning your data, you improve glycemic control, and there's less hypoglycemia. Normally, when you lower A1C, we just heard about sulfonylurea, so there's a risk of hypoglycemia. Here, less hypoglycemia, better glycemic control, just on how many times patients actually check the glucose. Remember, they don't know they're being watched, which is really scary. If you look at it a different way, more frequently patients scanned, more time they spend in range. Range is defined 70 to 180 milligrams per deciliter. That's your safe range. And less time again in hypoglycemia. The second generation of the Freestyle Libre is coming. Actually, it is already available in Germany and UK, because that will also have the alerts and alarms even without patient scanning. Because one of the problems here is, for example, you're asleep, well, who's going to do the scanning? So if you get a hypoglycemic episode when you're asleep, you would know. The new generation actually will have these alarms. So if patients want to, they can actually be woken up. They're like this. And the company promised actually it's not going to be any more expensive, so we'll see. So this is the CGM, which is the sort of classic. Now, Senseonics makes now the different system ever since. I don't know if it's available in India. You actually implant the sensor under the skin of the arm. And in Europe, it's approved now for 180 days. In the US, only for 90 days. And it's a totally different technology. But basically, the sensor is implanted under the skin. And you put the smart transmitter on that, basically like a Velcro, and it then sends data directly to your smartphone. It's an in-office procedure, which is a lot of fun. So you make a cut, and then you insert the sensor, and then you just put Steri-strips over that, and the patient goes home. And it's repeated then every 3 months. In Europe now, every 6 months. And again, the device then sends directly all the report data to your smartphone. How accurate is it? Well, again, if you look at this error grid, it's quite accurate because over the 90 days, 100% readings are in the safe range. And if you look at the famous MARD, again, and remember, anything less than 10% is accurate enough that you can make decisions about treatment based on the data, and it's certainly below the 10%. And actually, we were the first ones in the Midwest who injured a patient, a poor patient had a sensor inserted. And people actually like it because they don't have to worry about changing sensors, and we basically have to do it for them every 3 months. So let's talk about delivering insulin. So this is sensing glucose. Remember, the second part is delivering insulin, and that means you're in a device. So which pump do you choose? In the US, we are down only to 3 makers. So we have a choice, either the classic pumps, either the Medtronic or the Tandem. And the 630G system is the one in which the sensor, if the patient has both the sensor and the pump, the sensor will tell the pump to stop insulin delivery once the glucose level is low. So it's automatic. But the patient obviously has to wear both the sensor and the pump. The 670G, I mentioned it before, is the first hybrid closed loop system. What does that mean? It's not yet totally closed loop. It's hybrid, which means as long as the patient doesn't eat, it's automated. There is nothing the patient has to do. The sensor tells the pump what to do. And it makes a decision every 5 minutes to deliver insulin, not deliver insulin, and keeps the patient in the safe range. But when the patient eats, the patient still has to tell the pump, okay, I'm about to eat 20-gram breakfast carbohydrate. And so once the patient punches the number of grams of carbs for the meal, the thing knows what to do. But it's not smart enough yet to know when and what the patient eats. So again, this thing now has 2 extra levels of automation. It will suspend not when you are low hypoglycemic, it will predict. And if you're about to get hypoglycemia in the next 30 minutes, predicted on the trend, it will stop insulin delivery. So it will prevent hypoglycemia. You can imagine a patient who has diabetes, been on insulin for decades, the fear always is hypoglycemia. Think about their parents, okay, worrying about the kid getting a hypoglycemia episode in the middle of the night. This will prevent hypoglycemia. And so, as I mentioned, it automatically figures out every 5 minutes what to do based on those trends. The pivotal data, based on which FDA approved 670G in the US, showed that in all the patients, adults, adolescents, all of them, you can see in that red part how much tighter the glucose control was than in the same patients before they were automated. Okay, so the gray gives you the variability over 24 hours before they were in the auto mode, and the red one shows you how much tighter the glucose was with no hypoglycemia. Because this study, actually based on this study, was safety. FDA was concerned about safety. Not that your sugars are perfect, but is it safe? There was not a single case of DKA, not a single case of severe hypoglycemia, and FDA approved this after 3 months trial, which was unprecedented. The competition with the tandem, the t:slim X2 is talking to a Dexcom G6. Remember, I introduced Dexcom G6. And the automation, which is on the US market already, is so-called basal IQ, that it can predict, again, that you're about to get low in the next 30 minutes, automatically suspends insulin delivery so you don't get hypoglycemia. The control IQ, which will automatically give you extra insulin if you're running high, will be hopefully approved in the next couple of weeks. But how do you get insulin from the pump into the patient? Well, you need the plastic tubing. So you need an infusion set, and you need a cannula, which gets inserted under the skin, through which insulin gets delivered. The problem, of course, can be that you can kink. And the problem sometimes is the patient goes on DKA if somehow something happens and insulin doesn't get from the pump, in the subcutaneous space. So how about going tubeless? Insulet, the company, has been marketing this Omnipod, which basically is a fully disposable, fully functional pump. So every 3 days, the patient just, puts it on, and every 3 days just throws it out, and runs your life through this remote device. So there is no tubing needed anymore. So a lot of patients like it. You basically just put insulin in the back of it. You remove the adhesive, stick it someplace. Somebody can stick it on your back, doesn't make any difference. And then you run your life remotely, which is sort of nice because you don't need tubing. The Dash system now incorporates everything in a smartphone. So the patient will have information both about the CGM, the glucose data, but also the pump status. Okay. And so it's going to be, again, one less thing to carry around because most patients have a smartphone anyway. There is a sort of what's been called a pump for poor people with type 2 diabetes, okay, poor man's pump, which is a Vigo, which is an interesting device. And every day, the patient puts it someplace, you push one button, and basically delivers a steady basal rate. So there are no features. It's not no electronics, nothing. You just push a button, and it fixes either 20, 30, or 40 units a day. So this is obviously not for people with type 1 diabetes, for type 2 diabetes. And every time patient eats, there on the side is 2 buttons, and you push. Every time you click, it delivers 2 units. So the patient typically say, okay, this is a 5-click dinner, or this is a 3-click breakfast, okay? But every day you have to remove it, throw it out, and put a new one on. So this is a poor man's pump. So let me just summarize this part. I think that today, at least again, I'm talking about people on intensive insulin therapy. The insulin pump delivery and the CGM is standard of care because clearly patients, both the quality of life but also glycemic results, seem to be better. I already mentioned that there are several systems already in the market which automate insulin delivery. And so that, again, totally changes the quality of life for patients. There's one sort of less headache, and the fear of hypoglycemia is removed for the patients who are using these automated systems. And hopefully the fully closed loop system is going to be coming up soon. But what do we mean by the closed loop? Or it used to be called artificial pancreas. Now actually the official term is automated insulin delivery, or AID. Remember, this is not very sophisticated. And my engineer patients say, you kidding me? This is the artificial pancreas? Well, it's not artificial, it's certainly not a pancreas, right? I mean, basically, off-the-shelf sensor, off-the-shelf pump, and then you need the brains in between, which will, again, talk to each other and decide for the patient what to do. And so, as this is advancing, it's sort of interesting to watch. So the next generation, which is not on the market yet, is going to be 780G, which will try to get us a little closer to automating that delivery for bolus or for the meals, because right now the patient has to make a decision. So the new system will actually have a correction bolus also, which will get us one step closer to the fully automated stuff. Not to be left behind, Tandem, the competition, already is now testing this actually showed that it works, is this new control IQ system in which now everything is embedded in the pump. So not the smartphone anymore. So basically the sensor, you have the pump, and all the brains are already contained in that pump. This is moving fast. And again, I don't know how much impact it has for your patients, but it's been incredible to watch. For example, just to give you an idea, even though the 670G system was approved only 2 years ago, in the US, there are currently 180,000 people using the automated system, 670G. I mean, it's amazing how quickly that became adopted. This is what's expected over the next 6 to 24 months. It depends how quickly the regulators move, but hopefully there'll be more competition and obviously, hopefully more options for our patients. The other thing, of course, is that right now, it's very primitive. Remember, this is not pancreas. This is not artificial pancreas, because all it does, it delivers or not deliver insulin. That's all it does. Well, for most of you appreciate that glucose homeostasis is a little bit more complicated, just giving insulin. So the first step in direction, okay, let's be more sophisticated, is this dual pump. The problem is there is no soluble form of glucagon available. There are now 2 companies, actually 3 companies that are trying to convince the regulators that they have a product. And so this dual chamber pump is still a pipe dream. It works. The problem is that you don't have glucagon cartridge to put in there. So hopefully it's coming. The company is going to actually launch now trial only with the insulin to get something on the market. And hopefully with the next year, they can also have the dual chamber. And so the brain will make a decision, not just about insulin delivery, but also about glucagon. Because, for example, if a patient decides to go and exercise, just stopping insulin, think about it. If you just stop insulin and start running, guess what? That insulin, which got to the patient, still works. And so you cannot prevent hypoglycemia. The patients typically have to suspend the pump or decrease insulin delivery maybe 15, 30, even 60 minutes before they start exercising. This thing actually kicks in automatically glucagon. So this way you prevent hypoglycemia and the patient actually can carry on the activities, okay, as they would like to. But again, what are you gonna do with all this data? And what data are relevant? Because the amount of data is just overwhelming. And so Dr. Fonseca and I actually published this 2 years ago in Endocrine Practice, which basically said, we'll need to have something which can be hopefully interpreted by anyone, by the patient and by the physician. So different versions of this standardized report have been sort of published since then, and all device makers are making it, in which you can quickly identify not just the average glucose, but you can say how much time in green you spend in range, how much is above, how much is below, and on the bottom, so-called ambulatory glucose profile, that is, can you actually see the trends? Can you make decisions just looking at the trend, which actually is pretty easy once you know what you're doing? Because the problem with A1C, of course, is this. I mean, all 3 patients have the same A1C. Even from the last row, you can see that the patterns are very different, right? So you cannot make a decision based on A1C. And then also, FDA basically said, you cannot do estimated A1C because the old reports look at the data for 7, 10, and 14 days, and for the average glucose, they sort of faked the A1C. It was called E-A1C, like eGFR, okay? And FDA said, no, you cannot do that because you didn't measure A1C. So after negotiation with FDA, we termed this new term GMI, which does not stand for unfortunately, genital myocardial infections, but this is a glucose management indicator, and FDA said that's okay. So now we know it's not A1C, and you can look up the paper, and basically what the new reports now has, it's sort of fake A1C, but based on the glucose data, not measured A1C, okay? Now, the other thing, of course, is how do you define success? Because once you have the data, so this was now, again, definition. You have 5 buckets. You have time in range. You have 2 above in the yellow, above 180 and above 250, how much time you spend. And then 2 levels of hypoglycemia. And less than 54 milligrams per deciliter, less than 3 millimoles, has been decided to be clinically significant. So between 70 and 55 is alert level, less than 54 is clinically significant level to hypoglycemia. We had a meeting in Berlin in February to decide, okay, how do you define success? And then this was presented at San Francisco, the ADA, earlier this month. And basically, right now, what you strive for is to be at least 70% in range, if you can do that, okay? Again, 70 to 180. And so there are now companies out there which are trying to somehow automate it because, again, incredible amount of data. And so now we'll move to the apps. And basically, the idea now is people don't want to carry stuff around. And basically, the data are now being uploaded into the cloud. And there are companies out there in the cloud which analyze it and send back personalized messages to the patient. So I don't know what's going to happen to doctors in the future, because it's all coming to the cloud, from all the devices patients wear, and then back from the cloud, some specific, okay? Hey, Jerry, you better do something right now. And you have these things now already, this is available, and my patients are using this, okay? You can actually start analyzing what happened at a certain time. And what do you do on Saturday? What do you do different days of the week, okay? And there are now a bunch of these apps which are cleared by the FDA in the US, in which, again, you can start looking at specific patient-directed advice. What are you going to do with the data? And so how much insulin should I take? And you can have these devices tell you, okay, it looks like you need 27 units, okay? How much bolus should I make? Again, this is already on the market. And so again, the whole technology has moved so fast because now the patients already see on the smartphone, okay, I should do this, I should do that. Maybe I shouldn't do this anymore. And again, I don't know what's going to happen to us poor endocrinologists. So with that, I'd like to thank you for your attention. I'll be happy to answer any questions.
Thanks. Thanks, Dr. George. Can I have a few questions or comment? You showed that this technology has certainly taken care of rate of hypoglycemia, DKA, and type 1 diabetes, and have been tried in type 2 diabetes as well. So has it translated ultimately the macro and microvascular long-term complication in type 2 diabetes patients? Type 1 is okay.
So again, the question now is what to do with it. Because remember, and just make sure you understand, what I presented really is for people intensive insulin regimen.